Good afternoon. It is that time again. It's 4 o'clock Mountain Time, which means 6 o'clock on the East Coast and 3 o'clock on the West Coast. And my name is Dr. Randy Fink. Welcome to Fertility with Fink and Friends. I am the clinical director of IVF services here at CNY Fertility in Colorado, beautiful Colorado Springs, chilly Colorado Springs. I guess every place is really chilly right now. I'm also the medical director at the Miami Center of Excellence in beautiful Miami, Florida, where things are considerably warmer than they are here in Colorado, I think. But like every Tuesday afternoon at this time, it is our chance to get together and talk about things that are important to all of us, things about fertility. Maybe I can answer some questions for you. Maybe I can shed some light. Maybe I can give you a little hope when hope has been starting to wane. Sure, I'm glad to be here as always. And let's say hello to all those nice people joining. So we've got a couple of different social media feeds. We've got my Instagram right here, which is Randy Fink MD. And the very first person on is the superstar herself, Alexis Laurenti, who is a wonderful and very talented nurse practitioner at the Miami Center of Excellence in Miami. Great to see you here, Alexis. Alexis is a great person to see if you're in South Florida for straightening out all those women's health issues and hormone problems and doing all kinds of things good in your life. Hey to Leah, hi to Bailey, hey to Katie and Lex Blackwell, hey to Brock. The fabulous tongues are here with us today, as is my dear associate Brandis Montez, nurse practitioner here at CNY Fertility in Colorado. We've got Barbara Brown and Savannah and Melissa, my beautiful and lovely, wonderfully talented mother, who probably has my incredibly handsome and charming father not far from her side in beautiful lower Alabama. That's Mobile, Alabama. They are with me today, as they often are. Thank you so much for being here and for figuring out how to use the electronics on your iPad. So who else we got here? Let's see. On this side, this is CNY's Instagram page right here. Britt and Reese joined, Faith Waring. Let's see. We've got Whitney. We've got Mama of Boys times 4. I like that. Shabnam TKS. Hi. Good afternoon to you. That's Mimi. Is good to see you here, my friend. We've got Joan. We've got Natalie and boy, just all kinds of folks joining over here. And then right here in the middle, we have we have Facebook and LinkedIn and YouTube. And I see Heather is here with us right now. So Heather says, coming back to Colorado Springs for our third FET, we had 2 failed euploids using a gestational carrier and trying to decide between trying a modified natural and a medicated next time. Should we switch up from a medicated cycle like we did before? And should we use HCG boosters? And hey, also to Mrs. Keybell, thanks for being here. It's great, great question, Heather. I am a big fan of the modified natural FET. So you've probably heard me talk about this before, so forgive me if it's repetitive, but I think it bears hearing again. The medicated cycle FET is our default, and that's what we will go to most times. And there's 40 years of data behind it. That's what's been done in IVF since IVF was invented. And in the medicated cycle, we are giving you all the hormone that your body uses for the cycle. And in fact, we are suppressing your body's ability to make that hormone. So that's a medicated cycle. We know exactly how it works. We control every variable in that scenario. In a natural type cycle, we are letting your body contribute your own hormones. So instead of giving you all synthetic hormone that is coming from what we give you, we're letting you make it on your own. So you get a period. You develop a follicle in your ovary. That's an egg in its little house. And we watch that follicle grow just like every other month. That's where you make your estrogen. That's where your estrogen comes from. As that follicle grows and reaches to its mature size, we can trigger the ovulation. That lining, your uterine lining, is getting thicker and thicker because of that estrogen. We can trigger the ovulation, which tells the ovary it's time to release the egg, lets the clock start on when you're going to have your transfer. So it gives you a little bit of control over the logistics, over the timing of your transfer. But when the ovary releases its egg, that's when you start making your own progesterone. And that's probably where the magic lies in a natural cycle, because you're making your own progesterone instead of having to get the progesterone in oil shot. It is the progesterone in oil shot is one of our least favorite, one of our least popular accoutrements in the IVF world, second only perhaps to the HSG, the hysterosalpingogram test that nobody really likes to do. Nobody really likes to give themselves a progesterone shot. So the modified or the natural cycle lets you avoid that shot because you're making your own progesterone. Now, we still give you some vaginal progesterone. The modified natural is where we give you some letrozole or some ovulation induction, which makes sure that you're going to release that egg, but it also has a positive effect on the uterine lining. So I would certainly, Heather, think about doing the modified natural. It has a little higher success rate. Now, ultimately, that really comes down to the embryo, but still a little higher success rate, a little lower miscarriage rate, and there is a lower risk for pregnancy-related hypertensive blood pressure complications later on. So that's my recommendation, and in most cases it will be. So that's what I would recommend that you do. Now, you've also had a couple of euploid transfers that didn't work. So then, by the time you've transferred 2 euploid embryos, you're really at the point where we should have about an 85% probability that you would have been pregnant. Now, these were going into a gestational carrier for you, into a GC, but it makes me want to know for sure when was the last time her uterine cavity was evaluated, because that needs to be once a year. And has she been evaluated for endometriosis? Because, it's an 85% probability after 2 transfers, and that's certainly not 100%, but it's pretty damn good. So if a couple of euploid transfers have taken place, chromosomally normal embryos, and you haven't gotten pregnant, I think it's worth looking under some stones to see what we might be missing. So Melissa is here. Happy Tuesday, Dr. Fink. We had our 6th transfer today in Syracuse with Dr. Arroyo. Congratulations. I hope that will be good, happy news. The first, let's see, coming from Leah, our first embryo transfer was sadly unsuccessful. We have a call next Wednesday, but for planning purposes, would wonder if you could speak about the ERA, the Emma, and the Alice testing. Yes, indeed. So let's talk about the ERA test. And I do think that anybody who is doing embryo transfer should know what this is, because it is not something that everyone should be doing. I repeat, underscore, bold, it is not something that even most people should be doing. So ERA stands for endometrial receptivity assay. And this was predicated on the idea that most of us are the same, that 75% of us have an implantation window, that there is a period of time during which our uteruses, and by ours, I mean our collective uterus, as opposed to my own personally, that the uterus, we have a particular window, and it's 120 hours of progesterone. That is our implantation window. 75% of us fall into that window, which means that 25% of us do not fall into that window, that we need either more or less progesterone than what we give in a medicated cycle. That's what the ERA was for. It was for testing your unique implantation window, which sounds fantastic, right? I want to know what my implantation window is. It's my unique window. Maybe I'm different than other people, and maybe that's why things aren't working. I should be able to test that. What a great idea. The problem is that and it does really sound like a very good idea. when you when they study this sort of thing, and they look at tens of thousands of embryo transfer cycles, they find that people who have done the ERA, whose timing is either before or after, or for that matter, right where it's supposed to be, it really doesn't make a doggone bit of difference in terms of pregnancy rates. People are no more likely in general to get pregnant having done that test than not doing that test. So what it means is, while it sounds like a great idea, and it does sometimes give us information that appears to be useful, because, what if your number is, instead of 120 hours, you're at 140 hours? Well, I mean, I would want to know that. That's, it's a day later that you want to be having your embryo transfer. But the fact is that the studies show us it doesn't change the outcomes. So there are some fertility practices that used to make people do this test before they ever did an embryo transfer, and the data on that was also very, very clear. It doesn't help the pregnancy rates. Now we know that it is not a very good test for the general population. We generally reserve that test for the end of the road, when we've got nothing left to test. Like, let's say that you've had multiple euploid embryo transfers that haven't worked. Well, gosh, then maybe we'll do the ERA, because we don't know, really what else to do in that point. But the data suggests to us that it really doesn't help with pregnancy. So that is not something, Leah, that I'm going to tell you that I think you should do. The ERA is also packaged with another little test, which, in my personal opinion, may not be so useful, and that's called the Emma and the Alice test. The ERA, the Emma, and the Alice, which they affectionately called the endometrio, the trio of tests of the endometrium, that was designed to tell you about certain pathogens or certain bacteria, certain aspects of the bacterial flora inside of the uterine cavity. And again, that sounds like a great idea, doesn't it? Of course it does. The problem is with some of these great ideas is that they don't actually pan out to really mean a whole lot. So some of what that is testing is bacterial flora that's in the vagina. And there's really no evidence that shows that altering that bacterial flora, or having something, some particular type of lactobacilli, which is the normal bacteria in the vagina, that it makes a difference. It doesn't show that, nothing has told us that it really makes a difference in terms of pregnancy outcomes. So it's not an inexpensive test. So do you really want or need to spend that money? For what we're looking for with the M and the Alice is evidence of what we know as chronic endometritis. Endometrium-itis. So it's an inflammation, a chronic inflammation in the lining of the uterus. Okay, so that's chronic endometritis. To tell you the truth, we can do a simple endometrial biopsy that will be covered by insurance in most cases, that will tell us whether you've got evidence of chronic inflammation in the uterine lining. And if you do, then we typically treat that with usually 2 weeks of antibiotic therapy, doxycycline, to quell the inflammation that's coming from that chronic overgrowth, or that chronic infection. So, there may be some other alternatives there. The ERA, the Emma, the Alice are very popular on social media. People talk about them. You'll have someone say, "Oh my God, I never got pregnant until they did that test, and now lo and behold, I'm 30 weeks. So clearly, it's what made all the difference in the world." All I can tell you is kind of what our experience has been, and really what the published data shows on that test. So it's not typically something that I will routinely recommend. Hey to Kaylee, nice to see you. Hi to Zenaida from Miami, nice to see you this afternoon. Let's see what else we have. If you've been on birth control for 10 plus years, how long would you recommend before getting blood work for a baseline? Well, so, one thing that we do, so first of all, let me tell you, birth control pills and hormonal birth control is the best studied medication in the history of medical science. We know more about oral contraceptives and hormonal birth control than really about any other medication ever invented, which is incredible. In fact, in many cases, you can ask an 11-year-old, 10-year-old, and even 9-year-old girl, how do you keep from getting pregnant? And she may say, oh, you can take a pill. She may not even know what that means to, getting pregnant or how you get pregnant, but she's seen her sister or maybe mom or friends or somebody, you take a pill and that's how you prevent getting pregnant. So we know a lot. And this is to V Stars and Stripes. We know a lot about birth control. And what we do know for sure is that even long-term birth control does not cause infertility. So I just want to stress that because that is a myth that's out there. Birth control causes infertility. In many cases, I'll see somebody who has been on birth control, maybe you're 35 and you've been on birth control since you were 15 years old. And then you stop birth control and you have a hard time getting a period. You say, oh my goodness, well, look what that birth control did to me. It messed up my cycles. Well, you might not remember that when you were 15, you started on that birth control because your cycles were messed up and somebody was trying to regulate it, It is true that being suppressed, having your hormones suppressed, and that's called the hypothalamic pituitary axis. Suppressing that with birth control for long term, it can take a few months before the brain kind of figures itself out and starts having regular normal periods again. So that is not unexpected. The other thing that I think is important to know, especially for you, V, that the AMH level, the anti-Mullerian hormone, which is the blood test, for us as fertility specialists, it's probably the single most important blood test we want to know. It's called the AMH, the anti-Mullerian hormone. It is a reflection of your ovarian reserve. What does that mean? You were born with all the eggs you will ever have, right? So if you're 35, and this is kind of one of the things that I think is really unfair about the sperm/egg discordancy. Sperm that comes out today was manufactured in the body about 3 months ago. Whereas so it recycles every 3 months. Whereas the eggs in your ovary, and let's say that you're 35, they've been there since you were in utero. They were there for 35 years. And so the DNA that's in those eggs is 35 years old and it starts to have problems with its stability. And that's one of the reasons why it gets harder for us to get pregnant as we mature, because that DNA has been around for that amount of time. And so it can often cause, that's really the cause. And that's what we know of as egg quality. It causes eggs to have chromosomal abnormalities that cause embryos to have chromosomal abnormalities, and therein lies the problem. The AMH level, which is the blood test that we do that qualitatively gives us a number, but it's really more a qualitative assessment of your ovarian reserve, it can be affected by the birth control pill. It can be artificially lowered by a little bit because of the birth control pill. And it may take 3 to 4 months after stopping the birth control pill before the AMH returns to where it may be naturally. But so V, I think it depends on what kind of testing you're doing. If you're doing just some baseline testing, I think the information that we'll get from it is still very useful. Even the AMH level that we get while you're on birth control is still very useful to us. So I wouldn't necessarily delay things. And to be quite honest, I am very hesitant to tell people to stop taking their birth control unless they are damned ready to get pregnant, because there is another myth out there that you should stop your birth control 3 or 6 months or something before you intend to get pregnant, so that it can quote unquote clear out of your system. The reason that you take a birth control pill every day is because it is a daily dose. If you stop that pill today, it will be out of your system tomorrow. Right? So don't stop your pill until you're ready to be pregnant, or else you may find yourself getting pregnant when you're not ready to be pregnant. So stay on it. Hopefully, that answers the question. And by the way, we love the stars and stripes. Okay, let's see. Can we do, this comes from Shabnam. Can we do IVF with high sperm DNA fragmentation? Yes, yes, you can. And I will tell you what I recommend in that scenario. So let's talk about what that means, DNA fragmentation. What is a sperm? Sperm is a little packet of DNA with a motor on it, right? That takes it where it needs to go. So the average ejaculate will have about 50, well, the lowest number we expect is 15 million sperm in an ejaculate. And so when we talk about DNA fragmentation, we're talking about the genetic material in each of those sperms starting to become unwound, starting to become less stable, like it happens in the eggs, over time. Um, Again, I said that sperm is manufactured about 3 months ago. So if something is happening that is causing an insult to the sperm, and I always thought that was kind of a funny expression, insulting your sperm. Um, hey, you're very little. How do you insult sperm? You don't swim very well. Well, you can insult sperm in any number of ways. I can think of some less, or maybe some more colorful and less appropriate things that I could say to insult sperm. But if something in the body is insulting sperm, what insults sperm? Well, here's a good example: marijuana insults sperm. People who are chronic cannabis users will have a lower sperm count. They often will have lower motility. The sperm may not move around as well. Men who use hot tubs a lot will affect the sperm because of the body temperature. Hotter temperatures affect sperm production and sperm morphology, the way the sperm look, the way they function. So if you're insulting your sperm in that way, be careful about insulting sperm. If the sperm is being insulted, I just can't stop saying that because I like the way it sounds. There's so many places I could go with insulting sperm. The DNA in that sperm can start to be affected. So that's what's known as DNA fragmentation. And there is a test that can be done for DNA fragmentation in sperm, although I don't usually recommend it. DNA fragmentation or sperm fragmentation, as we know it, typically results in sperm that don't fertilize eggs very well. So it would result in the IVF world in a low fertilization rate of otherwise good-looking eggs. All right, so that's what sperm DNA fragmentation does. How can you fix DNA fragmentation? There are two ways to do that. The first is to increase the ejaculatory frequency. So sometimes I have been asked to put that in writing on a prescription so that the guy can take it home and say doctor's orders. So the more frequently he ejaculates, the lower the sperm count. So with each subsequent ejaculate, the sperm count does get lower, but the sperm quality gets higher. So by increasing the frequency of ejaculation, you can improve the sperm quality and thus decrease the DNA fragmentation. The other thing that we can do in the lab is a simple sperm preparation method that's known as Zymote, Z-Y-M-O-T. And if you go to the internet and you look at Zymote, you can look at their website. It's a good website and explains kind of what it does. Basically, it's this little device. It's like a little cartridge, and we put sperm in on one side of it, and it's like a little obstacle course inside that the sperm have to swim through, and the best sperm come out the other side of it. You have to have a minimum sperm count and a minimum amount of motility in order to be able to use Zymote. It's a little add-on, it's very inexpensive add-on. CMY doesn't really mark that price up. It's only like a $200 add-on to IVF. But what results in that is a lower amount of DNA fragmentation. So I particularly recommend that in couples who have otherwise really unexplained infertility, because one of the reasons behind that may be that it has something to do with DNA fragmentation. So we can really just help to select the better sperm by using the Zymote device. So yes, indeed, we can do IVF with high sperm fragmentation. Evil shenanigans. Good afternoon, evil. Questions on what to do. I'm at Syracuse this week in 12 eggs fertilized? Should I send them all to blast or should I freeze some early? Well, in general, Evil, we recommend that if you have 5 or more, unless there's some other special case scenario. If there's a special case scenario, it's something to kind of talk about with your providers there. But 5 or more embryos, I would recommend that you grow them to blast. If there are 4 or fewer, we recommend that you freeze on day 3 or that you do your day 3 transfer. I wouldn't split them up. I think, because it's very arbitrary which ones we would pick to grow and which ones to not. So you really want to, statistically, you do better by doing them all together. 12 fertilized embryos, I would grow to blast. Why? Well, there is nothing wrong with the day 3 embryo. And I think we had this conversation last week. If we're limited in the numbers, I would all day long rather see a day 3 embryo going inside of you than potentially dying in the lab. So all 12 of your embryos are not going to survive. We know that they're not. We're going to be using nature to help to select which of the embryos have the greater probability of being able to get you pregnant. So let's say that we had 12 embryos and we froze them on day 3. Well, they're going to go into your body and your body's going to tell us which ones are normal. Some of them won't make it, but it means that you're going to be doing a lot more unsuccessful transfers with 12 day 3 embryos. Whereas if you let those embryos grow to blast, then nature's going to help you select out some of that group, and it will just decrease the number of unsuccessful transfers that you have. Okay, hopefully that makes some sense. We got a lot of folks showing up here on the Facebook side, so I want to get some questions in over here. Mrs. Keybell asked, which is better, an HSG or a saline sonogram, because I don't have any fallopian tubes. If you do not have fallopian tubes, Mrs. Bell, do not do an HSG. An HSG is not helpful in that scenario. The HSG is the dye test where we place some dye inside the uterine cavity and take some x-rays. It's designed to show us the shape of the uterus, and it is designed to show us some features about the fallopian tubes. But in the absence of the fallopian tubes, the HSG is really not going to be a very helpful test. The saline sonogram, or an SIS, is a very helpful test because that shows us the shape of the uterus, but also really what's going on the inside of the uterus. Are there polyps? Are there scar tissue? Is there a septum? Is there, bands of muscle, something going on? So please, with no tubes, don't do an HSG. Saline sonogram is the way to go. And Shay echoes in here. You are right. The HSG does not hurt, does not feel very good. She says it hurts so bad, so painful, I wanted to die. We don't want you to die. And there's some more some ways that we can do an HSG that makes it more comfortable. It should not be something that you want to die from, but it certainly does cause cramps. Okay, let's see what here. Kate Shaw says, if an IVF patient did really awful with the Lupron flare protocol, but much better with an antagonist protocol, does that mean anything? Well, yes, it does. So you're talking about 2 different types of medicated protocols for IVF and the medications that we use for stimulating the eggs to grow. A flare protocol, my voice cracked there. I'm sure that sounded very cute. And yes, I am 13 years old. A flare protocol is an older method of doing things, and it really got abandoned for several reasons. The more common way that we do that now is, as you mentioned, an antagonist protocol. So we use Provera, or we as a pill, or we use Cetrotide or Ganirelix, and those serve the purpose of stopping the ovary from releasing an egg. We want to stop you from ovulating until we're ready for you to ovulate, because we want your eggs. We don't want you to lose them or to ovulate them on your own. People tend to do better with antagonist protocols than they did with flare protocols. So a flare protocol was a good way to go In the olden days, it's kind of what we used before these other medications were invented. And now they may sometimes be used for people who we just absolutely can't stop from ovulating, or in people who are at extremely high risk for ovarian hyperstimulation. And even then, we still typically use an antagonist protocol. So, not surprising, the FLAIR protocols never did as well as an antagonist protocol. So, what does it mean? It means that you updated your protocol, and that's probably a better thing. Okay, what else we got going? Rhonda's here. I'm 13 weeks pregnant tomorrow. Woo! In the first trimester and going into the second trimester. Congratulations, Rhonda. I hope you are feeling well. So, hopefully, by 13 weeks of pregnancy, the nausea and vomiting of pregnancy goes away. So it typically starts around 6 weeks. It usually peaks at around 10 weeks or so. And in most people, like about 85% of people, it's usually gone by going into the 13th week of pregnancy. So I hope for your sake you are not nauseated. Nausea is a crappy feeling, and adults do not do well with nausea. Little kids can puke and be back outside playing again in 15 minutes. As adults, we do not feel well when we are nauseated. We're on the couch and just never want to get up. So there are some good solutions to nausea and vomiting of pregnancy, by the way, should you be experiencing that. And that's something to talk about for sure with your OB. So congratulations, Rhonda. Sierra is asking, what about gender selection? How does that work? Gender selection is when, obviously, you want to pick a gender. You want to have either a boy or a girl. I talked to somebody today, a very nice patient who had done her PGT testing. She had 11 euploid embryos, and they were all girls. I'm like, wow, you are a girl's mom. Can I tell you one other story? It's a little bit of an aside, so forgive me. By the way, 33 minutes after the hour, we'll be here for about another half an hour on Fertility with Fink Friends. Throw your questions this way, would you? We're live from Colorado Springs, trying to get everything in here on this beautiful Tuesday afternoon. Okay, so here's the story I was going to tell you. I had a lady back when I practiced obstetrics, and I delivered babies. She had gone through IVF, and she had triplets. And this lady was just a lovely, lovely person. She was miserable. She was as big as a house. I mean, she was so swollen. She was huge. She had 3 really full size babies inside, and could barely walk, but was just so happy. She was just so delighted. And even when, triplets is not something that we really want for people to have, because it's a very high risk situation, and virtually guarantees you a preterm delivery. But to make a long story short, she did great. She had 3 boys. All 3 were boys, and they didn't want to know what the gender was of the embryos. So it was a surprise when they were all born, and there were 3 boys. So she came back for her postpartum visit, and I said, one of the things we always talk about at postpartum is that we really need to focus on, we need to make some decisions about what do you want to do to keep from getting pregnant. And she said, oh my heavens, gosh, after all that we went through in the fertility realm in order to try to get pregnant here, I don't need to do anything to keep from getting pregnant, because we did, I don't remember what her story was, we did a lot in order to get pregnant. So no thanks, and we're not going to do birth control. We don't even need condoms. I said, well, but once you have the baby, the plumbing changes, and things can be different. So I really strongly encourage you to, think about it, or follow your cycles, or use a condom if you don't want to do something else. Oh, no. Well, 4 months later, she returned to my office with spontaneous twins, also both of which were boys. And at the same time, her sister got pregnant also with spontaneous twins, also both boys. So the grandma, her mother, within basically about a year and a half or 2 years, had 7 new grandbaby boys in the family. 7 new boys in the family. So I like, gosh, Christmas just got really expensive. I don't know. That's just an aside. I'm not really sure what my point was there. But gender selection. So if she were to decide to have another baby, she might elect to have a girl instead. So what we do with that is that it's the same process of IVF. We give you the medication to stimulate the ovaries. We retrieve the eggs. Sperm goes into the egg. We create embryos, and then those embryos are grown out to the blastocyst stage. So typically day 5, but sometimes day 6 and sometimes day 7. And then that portion of a portion of the embryo, the portion that will become the placenta, which is called the trophectoderm. The outside portion of the embryo is biopsied, and they take a few cells, and those go off to the laboratory and comes back to us telling us which of the embryos are chromosomally normal and what is the gender. So that's how we do gender selection. It's a pretty straightforward process. My understanding is that there are some practices that refuse to do PGT for gender. I believe in Canada it is illegal to do PGT for gender, but in the United States it is a common reason that people will do IVF with PGT-A, pre-implantation genetic testing for aneuploidy, and that will tell you also the gender of your embryo. People do ask all the time, well, isn't there some better way to do that you can just pick the sperm that are going to create boys or the sperm that are going to create girls? Can't you do it before you reach that point? Maybe I don't want to make all those embryos that I might not be able to use. And unfortunately, that science does not exist. There are some companies that I have seen advertised on the internet, and if it's on the internet, it must be real, that say that they can, guarantee you, or that they offer you some sort of for the low cost of whatever it is. They will separate your sperm for you. But I have never seen any science behind that or any proof that that is something that works. So I would encourage you very strongly not to do that. I think that at this juncture is a waste of money. So, but that's how we do gender selection. Let's see, Emily Temple is here. Hello, Emily, on Facebook, currently stemming for my egg retrieval in Colorado. We will see you soon. So wear your winter coat. Actually, I think it's about 20. It's actually 28 degrees outside right now. It was 2 degrees this morning. And we were down in the negatives. But I took care of a lady today from Wisconsin, and she said, even though it was like 3 degrees when she was here this morning, she said it's like a summer afternoon for me, because when I left home in Wisconsin, it was 40 below, which is just, kind of mind-boggling. Melissa is asking, Receptiva was positive. Okay, so the Receptiva test is a non-invasive test that we can do to identify the inflammatory marker associated with endometriosis. So when we find a positive endometriosis test, and this is done classically, that diagnosis requires surgery, but through an endometrial biopsy, we can do that. When we find it's positive, then we treat you with medication for 60 days. Orilissa and letrozole prescribed, and an HSG ordered by a CNY nurse practitioner. Is that usually the protocol? Well, I do not order an HSG for that indication, and I do not think an HSG is an evidence-based approach, nor do I honestly think, everyone has their reasons, so I don't want to criticize anyone else's ordering practices. But in my experience, we often are doing HSGs for the wrong reasons. I understand why she was doing that. So the Receptiva test, and that marker that it looks for, is called BCL6. And BCL6 is an inflammatory marker that's associated with endometriosis, and it's also associated with a hydrosalpinx, or fluid that is collected in the fallopian tubes. I do not use an HSG to diagnose a hydrosalpinx. Why not? Because the book that is our sort of Bible in reproductive endocrinology, which is by a man named Spearoff, tells us that an HSG is not the right test to do for a hydrosalpinx. Any clinically significant hydrosalpinx should show up on an ultrasound. And the problem with doing an HSG for that is that, well, hydrosalpinx is a fallopian tube that's full of fluid, and the fluid that's in that tube is inflammatory and can wash back into the lining of the uterus, and that can kill an embryo. But if the end portion of the tube, hold on, let me just grab my friendly uterus, who often joins me on this program. So here's the fallopian tube, right? And if there is a blockage, let's say out here, okay, and we're putting fluid in from here, what's going to happen to this portion of the tube? It's going to expand, and it can look like a hydrosalpinx, fluid in the tube, because we are pushing fluid in the tube, whereas there may not be fluid in the tube there at baseline. So that is why an HSG is not the appropriate test for a hydrosalpinx, although many people do use it as such. So again, I don't want to criticize someone else's opinions, but in my opinion, the HSG is probably not indicated. Is the Orlis cycle dependent, or can it be started at any time? Really, you can start it at any time. So those medications are used. So classically, the way that we would treat that would be with a Lupron shot, that we would shut down all of your hormones with a shot that makes you feel miserable, because it does put you into a temporary menopause. The medications now that can be delivered orally are Orilissa and Myfembree, and these two medications, they're much better tolerated, have a much lower side effect profile, and that is 100% what I reach to first, and they can be started really at any point. Let's see here. Joy Anna May. Thank you for the call yesterday. Oh, my pleasure. Cycle day 1 decided to start today. Planning an egg retrieval and fresh day 3. The estradiol was high last fresh, and I think mild OHSS, but still did it. Had a miscarriage at 7.5 weeks. Should we change the trigger shot? Well, so if you have ovarian so generally our trigger shots at CNY are a combination of Lupron and HCG. If your estradiol level is high, we tend to either use much, much less HCG or not to use HCG alone, because that high estradiol is a marker for ovarian hyperstimulation. And when you get HCG is just much longer lasting in the body and can make you very sick for a very long time. It's another good example of when you're hyperstimulated, it's just not the ideal environment. It creates an inhospitable environment, let's say, for an embryo. May not be the ideal place, and so miscarriages are more common, as is a simple failure to implant. So as long as your estradiol is okay, then I would recommend both a Lupron and an HCG shot. Okay, what else we got going on here? Let's see. iCarly says, I've graduated and I'm definitely so nervous to stop my medications. Can I keep taking everything to 12 weeks? So congratulations. When she says she's graduated, that means she is pregnant and has been referred on to her obstetrician. Carly, congratulations. We can't wait to see your baby pictures. So really the most important medication that we use in these protocols is the progesterone. Progesterone is the hormone that continues your pregnancy. But by about 9 weeks of pregnancy, your body takes over. The placenta starts making your own progesterone. And so you really don't need the progesterone anymore. Is there harm to staying on it through 12 weeks? No, there's no harm to doing it, except that it's just more hormone really than you need. So congratulations, though. That is fantastic. JM Dots is here. I've seen a lot of differing info on how to best diagnose and treat endometritis. How do you diagnose and treat? So the recommended treatment for for endometritis, so it's diagnosed by the presence of plasma cells, which are an immune cell that pathologists can see under the microscope. When we do an endometrial biopsy or some tissue comes from the uterine lining, it goes off to the folks who look under the microscope and the microscope doctors, as I call them, and they see this particular type of immune cell known as a plasma cell. The plasma cell the word is pathognomonic, which means it is diagnostic. It is the way that we diagnose endometritis. And the recommended treatment for endometritis is doxycycline, 100 milligrams twice a day for 14 days. Now, we talked a little before about the Emma and the Alice test, which sometimes identify other types of pathogens that may actually more commonly be in the vagina than in the uterus, and some recommended treatments for those. But from an evidence-based standpoint, it is doxycycline 100 milligrams twice a day for 14 days. Let's see. L. Higgins says, I have my third transfer in Albany this Thursday. Best of luck to you, my friend. Praying this is the one. Well, it has to be, because obviously you're not familiar, I guess, L. Higgins, with with the rule book. Were you given the rule book for this whole process? The rule book says third time's a charm, and that is, of course, rule number 3. So third transfer, third time's a charm. You got this, my friend. How long do you recommend to lie down after transfer? Because I've heard varying times. We keep you lying down for 5 minutes. You really don't need to be lying down much longer than that. Embryos are good and sticky. So I always tell people you will see some discharge that happens after an embryo transfer. It is the stuff that we use to clean. It's the progesterone. It's the mucus from the cervix itself. But what it is not is an embryo. You cannot pee an embryo out. You cannot sneeze an embryo out. You cannot bounce it out in the car. Embryos are good and sticky, not going any place. 5 minutes. Bed rest after an embryo transfer is not recommended. Not recommended. We do suggest that you take it easy for a couple of days, which just means nothing overly strenuous. And as I'm fond of saying, no alligator wrestling, extreme snowboarding, helicopter skiing, scaling down mountainsides, that sort of thing. But travel is generally okay. We say keep yourself extra hydrated, and have somebody else carrying all of your steamer trunks. But walking around is not a problem. Going up a set of steps is not a problem. 5 minutes, I'd like you to lie down. So let's see. It looks like Satali. How about killer cells or the body rejecting embryos after being on an immune protocol? I've been trying to conceive for over 7 years. Got pregnant naturally with twins in 2019 and lost them at 6 weeks. And I'm so sorry to hear that. Then 3 failed IUIs, several chemical pregnancies. Finally, one IVF, and we got pregnant, but I started running a fever 10 days post-transfer, and suddenly the HCG dropped. Our other tests are way better than normal. So that sounds like certainly a challenging history. So natural killer cells are a form of immune cell in the body that sometimes can be associated with. Usually we would think of it as recurrent pregnancy loss, but occasionally you think of it as implantation failure. The treatment, so testing for natural killer cells is not an easy thing to do, because a lot of times the number of the cells is not the problem, it's the activity of the cells. And the assay or the blood test to be able to look at that is just not really all that accurate. So That's one of the reasons that we use intralipid. So, it looks like the milkshake infusion. The lipid infusion, it's like kind of an IV version of the keto diet. The real reason that we do the lipids is for NK cells, natural killer cells. So I would say 100% you should be doing that as part of the immune protocol. You mentioned, IUIs, no, they have a fairly low chance of working. It's a better thing than home intercourse, but still not a particularly high chance of pregnancy. And I would hand the um, um, chemical pregnancies, those are embryo issues. That's typically always a genetic or a metabolic issue with the embryo itself. So what that tells me is that you are able to implant your pregnancies, just for some reason they are not growing. And in that situation, it was an embryo factor. But then you get a fever. And when you get a fever, your core temperature goes up, and that can be toxic to an embryo. So I would have to wonder what that was you got sick with, because there are some known viruses that are embryo toxic, especially early in the first trimester. So I would have to wonder if that loss wasn't secondary to actually some sort of illness, or something that affected your body and raised your core temperature. But that's one of the reasons we use intralipid. So would strongly encourage it. Shannon Powell. Good evening. I have questions as to what to do. Let's see. I'm at Syracuse this week and 12 fertilized. I think we talked before. Should I send them all off to blast? Yep, we said I would do that. Like to do a fresh transfer. I'd like to transfer 2. Can I do that? It is definitely not recommended, Shannon. And the reason is, so we follow some guidelines from the American Society for Reproductive Medicine. And what we really want for you is to have one healthy pregnancy at a time. And since you're 25, the odds are very high that the DNA in your eggs is nice and stable and that you will have chromosomally normal embryos. So to put 2 back does increase the chance that you will have a positive pregnancy test. Well, hey, that's a great thing. But it does not increase the chance that you will have a live birth. So what that means is that, in fact, it's increasing the possibility of pregnancy loss, and we really don't want to go there. So what do I mean by that? Well, twin pregnancies, there's an increased risk for cerebral palsy. There's an increased risk for preterm delivery, sometimes severe preterm delivery, so that you end up losing both. There's an increased risk of birth defects. There's a greater odds of a prolonged NICU stay, and about a 10% possibility of having lifelong defects as a result of a problem relating to being twins. So one healthy pregnancy at a time is what we're really after there. We do not encourage people to try to have twin pregnancies, because bad things, unfortunately, statistically, just happen. So now, in most of our locations, we won't say no, absolutely we won't do it, but we really want you to understand that it's against medical advice. It's a bad idea to do it with your first transfer, especially with your first transfer. So there we have it. Let's see. What else we got going on here? AK Bond says, would you recommend to transfer 2 embryos having failed 2 FETs? Well, that sort of goes along with what we were just talking about. So would you transfer more than 1 embryo in that scenario? And that may be a situation where you can transfer more than 2. The first question is, are they blasts or are they day 3 embryos? How old are you? And that sort of falls into, we're able to sort of look at the guidelines from the ASRM and make a determination about, what is the best choice. But certainly, having been unsuccessful with a series of other transfers kind of says, well, okay, then we start being in a little better place to think about transferring more than 1. All right. Let's see. Hi, Monkey Mo. I like that name very much. How soon after birth can I do another frozen embryo transfer? We recommend a minimum of 9 months. a short interconceptual interval is the only preventable risk factor for severe preterm birth. So obviously that is something that for sure we want to avoid. Hi to Florida, babe. And let's see. What is Fink? That's a good question. Uh, I wonder what that means. I don't know. What am I? Who are any of us? Okay. Nancy, oh hi, Nancy Gomez is Nancy Bernard is here from Miami. Nice to see you. Ashton Zueli says thoughts on using Provera to prevent ovulation instead of ganirelix during an IVF stimulation. I am a huge fan of using Provera. So again, those are called antagonists. The antagonist job is to stop you from ovulating before we want you to ovulate, because when it comes time to ovulate, we want to be able to retrieve those eggs. The injectable antagonists are called ganirelix and Cetratide. It's one more shot to get, and people do break through those medications sometimes. In my experience, more commonly they break through Cetratide than ganirelix, but people can break through both of those medications. I do not recall a time that I've ever seen anyone break through Provera. Provera is dirt cheap. It's like $3 for a bottle of 30. It's a pill instead of a shot. It doesn't have side effects. And it probably works better, I think, than the injectables. It also has the ability to not sort of put a squeeze on the ovaries the way the ganirelix or the Cetratide do. So I love and would use Provera 100% of the time, except that if you're using Provera, you can't do a fresh transfer, because Provera is progesterone, and that will mess with your lining, and that will prevent you from being able to implant a pregnancy. So using Provera means that you are committing to doing a freeze-all cycle, or if you're doing PGT testing, you just simply can't do a fresh transfer. Be positive, girls. Lining was too thick on day 4. Oh yeah, that's a frustrating thing. I have hope that the cycle will be better next time, and I do agree. Our hope is with you, Barbara Brown. Post transfer, do you still recommend doing Omegavin? So Omegavin is the intralipid infusion. Do I recommend it? Well, so the ideal protocol is that you do it, around the time of embryo transfer, typically a day or 2 or even 3 before, and then you do it weekly through the first trimester. So that's the official protocol. For many people, pricing gets to be a problem, and sometimes also finding a center to do the infusions can be a problem if you're not being monitored at one of our CNY centers. So if you're being monitored with us locally, by all means, if you can do it weekly, I sure do recommend it. Oh, heaven sent me 444. Dr. Fink, you did my transfer, and I just found out last week that I'm pregnant with twins. Oh, my heavens. I'm curious to know how many embryos we transferred in you, but congratulations. Oh, boy, the adventure begins, doesn't it? Boy, that's fantastic. Oh, hello to Amber Vince in Kentucky, and Dr. Pena in Miami is here with us as well. Let's see, how much of the Pregnol is needed for the wash? It is a very low dose. It's just a little bit. And can I use the rest of the vial to do HCG boosters? The answer is yes, you can. Shine asks, I had 1 failed FET and 1 blighted ovum. Should I do PGT testing after my next retrieval? Well, in that scenario, the blighted ovum is an embryo that is missing its inner cell mass. And you can actually have a chromosomally normal embryo without an inner cell mass. So the other, I do think, gosh, if you have enough embryos and you do the PGT testing, it just takes a lot of questions out of your mind. You know what I mean? Because again, 65% probability with the first embryo, 85% probability of pregnancy by the second embryo, and 95% probability of pregnancy by the time you do the third one. So again, it lets us know that that it's taking a lot of the embryo factor out of the equation. So I would ask that you consider doing that. Let's see what else we got on the Facebook side. Dr. Fink, I am 45. This is from my IVF journey. I'm 45. I stopped having periods 2 years ago. I used fresh donor eggs with fresh sperm from my fiance, though we only got day 3 embryos. Fair enough. I've done 2 FETs without success. I recently had a biopsy to rule out endometriosis, and it was negative. At all of my FETs, I was told the labs, the uterine lining were good. Is there anything else I can do? This is the last embryo. Well, my friend, it sounds like you have really done all the things that you can do. At 45, the odds of having a normal embryo are going to unfortunately be very, very small. So what we can hope for is that we got lucky with that embryo, but all those things that you did there, it sounds like you did the right things in terms of checking everything just to make sure that we were not missing anything under those stones. So you're doing the right stuff, fingers crossed. Brittany Bingold says I went for an HCG blood test 11 days after a day 3 transfer. The HCG is at 15. That is low. I presume that you are not on HCG boosters, but HCG has to start someplace and it starts low. So what do? We repeat that blood test in 48 hours and we expect to see it double in most normal pregnancies. So Brittany, fingers are crossed there, my friend. Oh gosh, it looks like we are going to be out of time for this episode of Fertility with Fink and Friends, but it sure is nice to see everybody here as always on these Tuesday afternoons. I feel so blessed to be able to be a part of your journey and a part of your lives. As I always say, this, lead yourself with kindness and with love, and most of all, with hope. This whole fertility business is not the novel of your life. It is merely a chapter. And what are we here to do? We're here to rewrite that chapter. And thanks for letting us help do that. So until next week, I'm Dr. Randy Fink, live from Colorado Springs. God bless. We'll see you next time.